Good evening. Good evening, everybody, and welcome. It is my pleasure to be here and speak to you in the session titled Optimizing Outcomes in Patients with Hyperkalemia, Exploring the Role of the Family Physician. My name is Csaba Kövezdi. I am a nephrologist in Memphis, Tennessee. I'm a professor at University of Tennessee Health Science Center. And with me here today are, number one, Dr. Deborah Clegg, who you cannot see because unfortunately she had a canceled flight earlier during the day and couldn't make it, but she's on Zoom. So there is something positive that came out of COVID after all, and that we have these capabilities. So Dr. Clegg is with us live, and she will be participating in the diet section towards the end, by voice at least. You won't see her face. Now on the podium, joining me are Dr. Bruce Spinowitz, who is an Associate Director of Nephrology and Vice Chairman of Medicine at New York Presbyterian Queens and Professor of Clinical Medicine at Weill Cornell Medical College. And last but not least, we have one of their own, Dr. Jay Shubrook, who is a Professor of Primary Care Department at the Touro University California College of Osteopathic Medicine in Vallejo, California. Let's start with the first presentation then, which is my own talk, Recognizing the Risks of Hyperkalemia. You can see here my disclosures. The first slide, I'd like to show you a somewhat complicated slide, which nephrologists love. And I'm going to try to make it simple. All right, so this is the physiology of potassium homeostasis. As you can see in the middle, serum potassium is what we measure, but potassium has this interesting property that most of it is intracellular. So 98% of our total body potassium is inside the cell. Hence, what's outside the cell is a very, very small amount. What influences the level of serum potassium is what comes in and what goes out. Right? What comes in is determined by diet. My dietary intake can vary. Today's dinner was a very nice potassium-rich dinner, which is healthy, and as we'll discuss at the end. Interestingly, colonic excretion is only 10% of what we take in on average, and it's very fixed unless you have decreased kidney function when you're on dialysis. But everybody's just about 10 millimoles a day, and that's it. So the regulation doesn't happen at the gut level. But serum potassium is affected by how much potassium is shifted into the cells, and you see all those boxes. That's affected by a lot of things, metabolic factors and, more important, medications. And then the most important thing is, as a nephrologist, of course, is the kidneys. All right, so the kidneys determine how potassium excretion is increased or decreased depending on the need, which is largely determined by the dietary intake. So on a day-to-day basis, these things have to be balanced. And obviously, if kidney function decreases, then we have a problem. And that's why CKD is the most important risk factor of hyperkalemia. So before we go into discussing what we do about hyperkalemia and what it does to you, it's important to define what we mean by hyperkalemia. So this is important because potassium is a continuous variable. So we need to have these arbitrary cutoffs whereby we will agree that if it's higher than that, then it's abnormal. Okay, and I have to tell you that there is no uniform agreement as to what that cutoff should be. And there is the normal lab value that the lab gives you, which is usually something like 5 or 5.1, 5.2, depending on which lab you're using. And that's just based on a population distribution, right? But, those of you who work in clinical practice, usually you don't sweat it when somebody's potassium is 5.3, 5.4. You have to be higher than that to think that it's clinically important, and that could be 5.5 or 6, depending on your level of comfort. Okay, there is no uniform agreement as to what's the cutoff that determines a clinically significant, let's say, malignant hyperkalemia. And the reason for that is because all the studies that I will show you show that it's a linear association with outcomes. So all of this is somewhat artificial, and it's meant to promote research, to promote our understanding and our practice. But be aware that there are limitations to this. So how common is hyperkalemia? Well, my guess is that in most of your practices, it's probably not very common. Because in patients with normal kidney function in the general population, the data that we have shows that it happens maybe in 2 to 3% of the individuals, all right? And even that data oftentimes comes from hospitals, okay? So it's not the healthy walkie-talkie population that may come for a healthy physical, right? However, in certain groups, it becomes very common, right? Like my patients, it's an everyday occurrence, right? Patients with very advanced CKD, it can happen very frequently. And in dialysis patients, it's almost like normal to have high potassium pre-dialysis. What are the main risk factors? Well, comorbid conditions, talk about CKD, diabetes is another important one, and then there's medications and diet. And we'll touch a little bit about on each one of these. So how about the mechanisms that induce hyperkalemia? And now you've seen what nephrologists love, all of this stuff that is too complicated to even talk about in the slide, but I'm going to try to editorialize and make it simple. So you see 4 disease states in the 4 corners here. Okay, on the north side is all kidney, right? So you have CKD and you have AKI. And all of these can have a lot of conditions and a lot of pathologies that through various mechanisms can induce hyperkalemia, whether it's just a decreased GFR or tubular dysfunction or metabolic acidosis or anemia or tissue injury with AKI and so on and so forth. Okay, and then down south you have diabetes and you have cardiovascular disease. And with diabetes, it's mostly physiologic in the sense that you probably heard about hyporeninemic hypoaldosteronism. So there is this physiologic decrease or insufficient response by the renin-angiotensin-aldosterone system. And also you have the relative insulin deficiency and insulin resistance, which will make it difficult to hide potassium inside the cell. So you will have problems with shift. Now, for cardiovascular conditions, it's mostly drugs, okay? Because cardiologists like to drown their patients in drugs, okay? They don't use 1 drug or 2 drugs. They use 4 drugs and 5 drugs. And many of these can cause high potassium, and if you stack them on each other, you end up with these medications conspiring. Then you see the listed medications there. So when we look at large populations and we try to identify risk factors of hyperkalemia, as we did in this large meta-analysis of this was more than 1 million patients. You see the usual players, ACE inhibitors, ARBs showed up. Diuretics, opposite effect. So we use that to our advantage. They cause hypokalemia. Diabetes, obviously EGFR, the lower, the higher the risk. And then interestingly, black race, as it's listed here, had an association with a lower risk. And that in itself is an interesting discussion. It has a variety of causes. In fact, we don't really have time to go into those today. So what is the clinical significance of hyperkalemia? Why is it that when the lab calls you about hyperkalemia, first of all, why does the lab call you? And why is it that, you don't just brush it off? Well, it's mainly because we fear that something like this might happen to our patients. And I have to say that this is an extreme case, okay? So this was in New England Journal of Medicine many years ago. It was a patient with a potassium something like 9, okay, where you will see this sine wave pattern, right? Interestingly, all it took is calcium. You don't even have to normalize potassium. You give them calcium and then you see a returning to a more normal electrophysiologic pattern. But the bottom line is that potassium affects the membrane potential, okay? And when hyperkalemia occurs, then you have a problem with these. And anything that's electric, okay? The heart wiring, the muscles, the brain, but it's the heart that will kill you. So how does this translate into, again, we go from 1 patient to a large population. This was one of the seminal studies that many, many years ago looked at the association of hyperkalemia and an ER, okay? And looked at the association with potassium levels with 24-hour mortality, okay? So it was really the short-term effect, again, linking it to maybe arrhythmias. And it was grouping the outcomes according to CKD stages. So on the left side, you see patients with no kidney disease, and then you have patients with worsening stages of CKD. But interestingly, the shape of the curve is the same in all 3. So high potassium was associated with higher mortality, but it's interesting to see that the height of these bars is much, the bars are much taller in patients who have no kidney disease. And that's kind of a mystery that, there are different explanations or theories. Some say that patients with CKD, quote unquote, get used to higher potassium levels. So because they experience it more often, they develop these protective mechanisms, and that's why you don't see such a massive increase in risk with a higher potassium. Others would say that potassium is rare in patients with normal kidney function, and to have a high potassium in that group means that you're really, really sick. So they blame unmeasured confounding on these associations. But either way, I think it's a very interesting thing to have a 30-fold increased risk of mortality if you have a high potassium, which is more than 6 in somebody with normal kidney function. So, and that risk is really independent of their major comorbidities. And that's shown nicely in this study that grouped patients according to what comorbidities they had. So you had a control group, then you had the diabetics, you had the ones with CKD and heart failure, and then you had those with all three. And while the baseline risk increased as you stacked on more and more comorbidities, the U shape was present for all of them. So really, the association with a certain level of potassium compared to patients with the same comorbidities was just as. And again, what other risks are affected by high potassium and low potassium for that matter? Again, this was from the same meta-analysis that we did in more than 1 million individuals. And as you can see, of course, all-cause mortality shows that increase cardiovascular mortality, which gets you closer to this hypothesis that maybe this is arrhythmia-mediated, the risk. And then interestingly, ESRD risk was higher in those with high potassium. And that was really a head-scratcher for us because we don't know of any mechanisms whereby high potassium would be toxic to the kidneys. So this is probably what's called reverse causation, in that those who have high potassium probably have more pooped-out kidneys. Even at the same level of eGFR, they may have poorer tubular function, more fibrosis, so they are more likely to reach end-stage kidney disease. So it was an interesting epidemiologic phenomenon that was described here. So with that, I'm going to switch my talk and focus more on medications. And the reason for that is that that's really the crux of where our dilemmas are nowadays. And you'll see at the end how this all comes together. Of course, what would everybody do when you're called with a real high potassium, not a 5.1, but let's say a 6. Most of us would look at their medications and, hey, this patient's on spironolactone or losartan, so let's hold that and let's do something. So those two classes, RAS inhibitors and MRAs, are really at the top of any medication list that is listed as, what are the medications that can lead to hyperkalemia, and because these are very commonly used. Okay, because of course, succinylcholine is associated with hyperkalemia, but I've never used it, so what do I care? Okay. So what data do we have? There's a lot of data. Okay, I just wanted to show you something more up to date, which was interesting. I mean, these investigators looked at combination regimens, and for a while we were really trying to stay away from these, like ACE inhibitors and ARB. After the nephron D studies, we said that it leads to more AKI and more hyperkalemia, so that combination was dropped and actually is contraindicated. Nevertheless, there's still patients on those, and as you can see in this study, it was associated with higher risk of AKI and hyperkalemia. But interestingly, they also compared patients who are on the combo RAASi plus MRAs and RAASi plus non-steroidal MRAs, the latter one being the finerenone. You probably heard about it in the middle. And that's important because there's still disease states where you have guidelines that recommend these combinations, okay? And for those, interestingly, there was no association with AKI, so that was comforting to see. But there was an association with higher potassium levels. Now, interestingly, the steroidal MRAs, the spironolactone and the eplerenone, showed a much, much higher risk. It was like a 5-fold higher risk of hyperkalemia as opposed to a 2-fold higher risk with the non-steroids. Of course, as you know, the big selling feature of finerenone is that it's less hyperkalemia inducing, but that's for another day. So what should we do about RAASi? Okay, so we all like guidelines because they tell you what to do, right? So it's a bunch of smart people who sit down in a room and then they have a nice meal and then they come up with something smart. So unfortunately, sometimes there is just too many of these guidelines and you're in real trouble if they don't say the same thing, all right? So there you go. There is a listing of all the various smart things that they said about what to do about potassium, all right? So especially because there is no uniform cutoff and uniform clinical trial-backed action, we're all relying on expert opinions, which is basically our own experience and knowledge. So everybody pretty much agrees that if the potassium is more than 6, then you should stop the RAASi, okay? I don't think anybody has a problem with that. Where we end up with a lot of murkiness is around these lower levels where, some will say that lower the dose, others will say stop it, restart it, don't start it. As you can see, in general, guidelines will say that if the potassium is more than 5 at the outset, do not put somebody on a RAASi or an MRA at that point, okay? But you may want to do something about that potassium because you may need to make room for that medication. So that's the essence of this. As you can see towards the bottom, they say a potassium-lowering agent should be started because those can help us get patients on these medications. And of course, at the bottom, if the potassium is normal, then very importantly, don't be happy with the lisinopril dose of 5 milligrams a day, right? Because those homeopathic doses don't do us any good. You need to maximize the dose of these RAS inhibitors. And importantly, what's not widely known is there is no data to suggest that the propensity for side effects like hyperkalemia is dose dependent. So it's not very likely that somebody who is on a 10 or 20 milligram of lisinopril will develop hyperkalemia. Now, I don't know if that's true, but that's what the scientists say. So I'm going to throw in a curveball here, all right, because this question comes up, all right. This is what you see on the right side is what we call the heat map in nephrology. And it's really caught on in the past 5-6 years in various guidelines. And it's meant to popularize our staging of chronic kidney disease, all right? So we all know that we have EGFR, and then we have these cutoffs of 90, 60, 45, 30, and 15 that grades CKD stages through G1 through G5, all right, as you can see there. But there is also albuminuria, and it's very, very important because what we're learning from large databases is that albuminuria is still not used as a screening tool often enough, especially in high-risk patients. And it's important to recognize that using cutoffs of 30 and 300 milligrams per gram, we can classify patients in categories A1 through A3, A1A to A3, which would be a separate categorization of CKD severity. And then based on a combination of A and G, you have these boxes. And as you can see, you have the normal person there with a EGFR more than 60 and no albuminuria. Those are green, which means that they are at low risk. They are your reference population, and you need to screen them. Okay, so if they're diabetic, then they need to be screened because they don't have kidney disease, but you need to watch for it. Now, the other groups, if you detect them, then you can see where the recommendation is to treat, and that's meant as a recommendation for everybody. Okay, because the question comes up, when should I send somebody to see a nephrologist? So this gives you a good handle as to what is the cutoff where I should consider sending this patient to a specialist, because at some level, a nephrologist cannot possibly see all patients who have a normal EGFR and a UACR of more than 30. There's a lot of those patients out. Okay, so those patients need to be treated by their primary care providers. And then you have the sicker ones on the edges. As you can see, the lower the EGFR and the higher the albuminuria, those categories are all recommending referral, but also treatment. Okay, so we need to have this shared model where we both apply the necessary treatment, because that way we can achieve better results. And the importance of it is on the left side, you see the association with cardiovascular death and with kidney events. And it's a very similar graph in that the more severe either category is, the worse those outcomes are. And obviously they're additive. So they're independent from each other. High albuminuria and low EGFR, they're additive effects. So back to our ACE inhibitors, why are they important? And I didn't bring you any clinical trial data because you know that, and this was an observational study in veterans where there was an association with higher mortality in patients who were not on ACE inhibitors. These were patients with chronic kidney disease. Okay, quite a nice association. And then there was another observational study that looked at outcomes in patients who were on maximum dose, on a lower than maximum dose, and on no RAS inhibition. So as you can see, there is a graded association with increased mortality, irrespective of which patient group you looked at, whether it's CKD, heart failure, diabetes, or all patients, indicating that not only is it important to have patients on these medications, but it's important to have them on a maximum tolerated dose, because that confers the lowest risk of all. Not surprisingly, the guidelines, and KDIGO is our nephrology guideline, but this is very similar in all guidelines in that they recommend RAS inhibition as one of the one of the first line medical interventions in patients with diabetes in this case. I also circled non-steroidal MRAs, which at least in this guideline are one step behind, but I have to say that the cardiology guideline, the diabetes guidelines, the Europeans, they all bring them to the same level. So, we're not going to split hairs here. They're also essentially inhibiting the same system, only through different mechanisms. Of course, again, showing the cardiology guidelines, this is for HFrEF, those patients with low ejection fraction less than 40. You can see this is the cocktail that I was referring to. You have ARNI and Entresto, and or the RAS inhibitors, MRAs, beta blockers, SGLT2 inhibitors. They're all recommended at the same level in this population. Okay, and so this is our guidelines, and this is what we need to follow. But then what should we do? Okay, because I just told you that all of these medications are strongly associated with hyperkalemia. So we end up with this conundrum, okay? We end up with this dilemma, all right? I have medications that I have to use. The guidelines tell me to even stack them. But then when I give it to my patients, then they will develop hyperkalemia. So where is this balance? Okay, should I stop the medication because I'm afraid that the hyperkalemia will kill the patient, but then I deprive my patient of a life-saving medication so they may die a few years later from CHF or from whatever, cardiovascular or renal complication they might develop. So the key is to find a way to have both, okay? And we want to have both have our cake and eat it, okay? There is your cake. So how are we doing in clinical practice? Okay, well, not very well. So this is European data. It turns out that in Sweden and Denmark, they have these databases where they know everything about their patients. And this particular study looked at prescriptions and then fills of these various medication classes in patients with heart failure. So this is a sick population that, again, has very strongly worded recommendations to use these agents. You can use the beta blockers as reference. You can see how uniformly high is from patients with normal kidney function to all the way to patients with CKD stage 4 and 5. Okay, so no problem giving the beta blockers. Interestingly, fewer patients fill the medication than the prescribed percentage, but that may be a system issue. However, when you look at ACE inhibitors, when you look at MRAs and the triple therapy, first of all, you see a much lower percentage use of MRAs, okay, than ACE inhibitors, and that's well known even in this population. And then the worse the kidney function, the lower the percentage of usage. And those with advanced kidney disease will have maybe 60% RAS inhibitor use and like 20% MRA use. And when you get into triple therapy, about 10% of them will get the medication that's needed. Okay, and so that's data that we know that's there, and it just illustrates from a large population that the problems that we sense there, that the discrepancy, that tension does exist in clinical practice. What drives these outcomes? These poor utilization outcomes. So this is a study we did when we looked at AKI and we looked at hyperkalemia events in a large veteran population, national database, and then we linked that to ACE-ARB exposure. And just to simplify this graph, what we found is that interrupted use or non-use were both associated with these outcomes. So patients who displayed hyperkalemia were much less likely to use ACE inhibitors. And those who had AKI events were also much less likely to use ACE inhibitors. And this was true for total non-use or for interrupted use, using different definitions. So that's all I had. We're not going to take questions, but I'm going to hand over the podium to my friend, Dr. Bruce Pinowitz, who's going to tell you how to enable RAS inhibitor.
Joe Pinowitz. Yes, we're going to shift from the rationale for the important role of the newer potassium binders in the management of hyperkalemia. And hopefully by the end of this talk, you will be as convinced as I have been over the last few years of the major impact that these new binders have had in the management of these patients. These are my disclosures. So I won't spend a lot of time on this, but I really put it up because I wanted to mention something about the acute management. So you see typically if we see a very severe high elevation of potassium in the emergency room, emergent hyperkalemia, certainly calcium to stabilize the membrane, glucose, insulin, and arguably maybe bicarb to move the potassium into the cells. Arguably, if the patient is overloaded and has renal function, diuretics may actually rid the body of some potassium. Beta agonists are shown here. And I just want to put this, consider short-term potassium binders. And although the package insert of the two compounds new binders that I'm going to talk about specifically say they should not be used in emergent situations of hyperkalemia, there's a role for these in the acute management. I'll just mention a very brief study called REVEAL-ED. I'm not going to put up the data. It was a very interesting study. It was basically an observational study, patients coming into the emergency room with hyperkalemia. And what they did was they monitored the potassium after they were treated with any number of these interventions short of dialysis, and measured the potassium at 1 hour, 2 hours, and 4 hours. And I want you to remember those numbers. The mean decrement of potassium at 4 hours with all the things that we do for acute hyperkalemia was a decrease of 0.9 milliequivalents. Remember that number. We're going to come back to it at the end, and you'll see what I'm stating about the potential additional benefit of the binders in the even the acute urgent situation. Long-term management, as you see the way we approach long-term management of hyperkalemia, that is to say patients who have recurrent hyperkalemia, usually they have underlying diabetes, CKD, heart failure, and they're on RAAS inhibitors, and they should stay on those for the treatment of their comorbid events. Dietary counseling, we'll have occasion to discuss that. Obviously, it's difficult for these patients to alter their diet between the heart failure, the diabetes, no carbs, no fats, no salts. There's nothing left to eat, and then we're going to take away the fruits and the vegetables. It's really an impossible situation. Diuretic therapy certainly induces kaliuresis, but there's a variable response. And it used to be the guidelines, believe it or not, had modify RAS inhibitor therapy as the next move. And that's counterproductive for these patients in terms of their comorbidities. What's happened now is that with the use of these novel, new, well-tolerated, effective binders, that has moved in front, and it's made the management of this chronic hyperkalemia very, very different. So let me just spend a few words on the classic SPS, sodium polystyrene sulfonate. It comes as a calcium version, calcium polystyrene sulfonate in the Pacific Rim, a little bit of EU as well. And it basically is a negatively charged resin. It's charged, in this case, with sodium, as you see. It can exchange for potassium, in vitro 3 milliequivalents for every gram of SPS. In vivo, somewhat less, and the reason for that is there's competition with other cations, calcium and magnesium. SPS really is not very effective until it gets, as you see, further down the colon, where you can see that, I guess, light blue line is the potassium, starts to increase the concentration. And even though there's still competition for binding of calcium, at this point, potassium concentration is high enough that you do get binding of potassium and movement out through the fecal route. But that SPS has to get to the distal colon. The SPS has been around since the early 1950s. That predates our modern FDA that is appropriately fixated on efficacy and safety before a drug is approved. The ability to get a drug approved prior to the development of our modern FDA was really quite simple. In fact, SPS was approved in the late 50s, early 60s on the basis of a 30-patient study. They were treated with 40 grams of SPS for anywhere from 2 to 6 days, and there was a decrement of potassium of 0.4 milliequivalents. Done, approved. No comment about safety. And Rick Stearns appropriately raised this. This dated 2010, question whether it was safe and effective. And it wasn't until 2015, you're looking at the one and only placebo-controlled study showing that SPS does in fact work. You see is a huge study, 15 patients in each arm. Patients were treated with a daily dose of SPS, mean potassium 5.2 in both groups, and you can see that there was a statistically significant greater lowering of potassium in the SPS-treated group at the end of that 1 week compared to the placebo. And this is it. This is the only placebo-controlled study. There's a slightly larger one, less well-designed, with looking at calcium-based, the CPS, not SPS. Safety issues came to the fore basically when there were case reports of colonic necrosis in patients who were being treated with SPS. The suspicion was that it was associated with the use of sorbitol. If you recall, it used to be packaged with 70% sorbitol. The reason for that was, well, let's get the caxlate to the colon faster, so we'll give a laxative. Fact of the matter is that the potassium lowering may have been as much due to the laxative as to the SPS. But there were case reports of colonic necrosis, very often seen in the perioperative state. It was initially thought that it was due to the sorbitol. 70% sorbitol was verboten. Cases reports with 30% sorbitol was seen, even without sorbitol, non-perioperative. And so there's this issue about colonic necrosis. But be that as it may, SPS is not well tolerated. Any number of observational studies have shown that by day 7, patients are usually not taking it. This is two studies. I won't go into great details. One Canada, one Sweden, look at large databases. They looked at people who were emergency room hospitalizations for serious GI side effects, not necessarily perforation, but serious GI side effects, and the frequency of use of SBS in those instances was much greater. So you have a compound whose efficacy is questionable, whose tolerability is very questionable, and whose safety is an issue. And hence, there certainly is a need for newer binders. And fortunately, we have two that are on the market. Let me go over some data with respect to patiromer. So patiromer is an organic anionic polymer. It's a calcium-based. You see the calcium. Sorry, I can't point. There's a calcium. If you look at that right-hand panel, it's calcium is the counter cation that is exchanged ultimately for potassium. It's insoluble. It's put in suspension. You can see there are nice little circles. There are homogeneous beads, if you will, of this compound. If I showed you a picture of caxylate with all its spikes, you'd appreciate why it may cause colonic necrosis. That's a little too graphic. But this looks, this is the way the compound looks. It is nonspecific in terms of its binding, and there is some binding of magnesium. And so we'll discuss when I mention some of the side effects, the hypomagnesia that has been seen. But let's just walk through the various phases, because both of these compounds that I'm going to tell you about have had extensive testing for efficacy and safety. This is a phase 1 study that looked at the pace at which potassium is lowered. So 25 patients were brought into a metabolic unit. They had fairly moderate potassium levels, 5.5 to 6.5. They were given patiromer 8.5 grams twice daily. You can see the arrows. It's a 2-day study. And the time points there, the asterisk is over hour 7. So this is not a placebo-controlled study, but that's the first time point at which the potassium is statistically significantly lower than the baseline. Small decrement, but statistically significant, hour 7. With continued time and subsequent 3 doses, you can see that potassium does continue to decrease, such that at the end of 48 hours, there's a mean reduction of potassium of 0.75 milliequivalents. That was the phase 1 study. There was a phase 2 study, the Amethyst DN, which is basically in diabetic patients, hyperkalemic, all on RAAS inhibitors, mild and moderate hyperkalemia. These patients are dosed accordingly based on the mild versus moderate. We're given less for the mild, more patiromer for the moderately hyperkalemic patients. And you can see it's a 52-week study, long-term study in terms of maintenance of potassium. Again, not placebo-controlled, but this, again, shows the long-term efficacy and safety data was obviously gathered in this study. In the core, the pivotal phase 3 study, it's a little complicated, is Opal HK, published in 2015. It's a 2-part study. The first part was a single blind, but not placebo-controlled. Patients with mild or moderate hyperkalemia were given appropriate doses of patiromer based on the baseline potassium. And the primary endpoint of that first 4-week Part A study, uncontrolled, no placebo control, was the change in potassium at the end of the 4 weeks compared to baseline. About half of those patients, those with the more severe potassium at baseline, the 5.5 to 6.5s, who had responded, were then randomized to a withdrawal phase. So now these are patients who were controlled. They were continued on their RAAS inhibitor throughout this study. Some were given placebo. The other half were given patiromer. And the endpoint here was a change in serum potassium from that initiation of Part B. The Part A results, you can see significant decrements in potassium, both in the mild and the moderate, significant decreases in potassium. So this was the open label part of the study. And here, the withdrawal phase, you can see that compared to patiromer, the placebo patients had an increase of 0.7 milliequivalents, basically showing in this placebo-controlled part of the study the efficacy of patiromer. Based on this, patiromer was approved for the treatment of hyperkalemia. With respect to side effect profile, the main side effects were really, if you follow both, on the left is the part A, right is part B. You can see as you go down, the GI side effects were somewhat higher in patiromer, certainly compared to placebo on the right-hand side. So the GI side effects, not overwhelming, but not a lot of discontinuations based on it, but GI side effects were seen, and there was some hypomagnesemia seen in that in those patients. Shifting to some post-approval studies, there are a number of studies that, utilizing patiromer, the intention was to see its impact in terms of maintenance, allowing for proper treatment of comorbidities with, in particular, the RAS inhibitors. As Dr. Vesdi showed you, there are any number of real-world studies that show the frequency of either lowering the dose of RAS in diabetics, hypertensive CHF patients, and the consequence of that in terms of increase in mortality. So the objective in these few studies was to show the impact of the availability of a well-tolerated, effective binder. And this was the AMBER study that looked at resistant hypertension. So these are patients who are on 3 or more antihypertensives with control or without control, typical resistant hypertension. And one of the approaches for these patients, even if you don't prove that they have primary hyperaldosteronism, but the appropriate next step for treating these resistant hypertensive patients is to use an MRA, a mineralocorticoid receptor antagonist, in this case, spironolactone. So what they did in this study was take those patients, resistant hypertension, and treat them with spironolactone and patiromer versus spironolactone or placebo. And what they were able to show was that the time to development of a serum potassium greater than 5.5 was much more frequent in the placebo-treated. Discontinuation of spironolactone was much higher, double in those patients who were receiving patiromer. So this is the facilitative capacity of patiromer. This was a lot of words, and I'll just sort of mention it briefly, the DIAMOND study, which was intended, really a very noble undertaking, and that is to show that with the use of patiromer, that you would achieve in heart failure patients not only the appropriate therapy for the comorbidity, but have an impact on the cardiovascular outcomes. Unfortunately, they ran into COVID. Enrollment was limited, but they ended up taking a look at what they had, and the primary outcomes that were looked at were just change in potassium in patients who were treated with patiromer. And you can see that the control patients had a higher increase in potassium as opposed to those on patiromer, and the continuation of the MRAs, the discontinuation was significantly higher in those patients who are on placebo versus patiromer. Again, the utilization of binder. And I just would throw this in. Dr. Kabezi authored this paper. It was gleaned from a large database, taking a look at the dialysis population. You know that our patients are dialyzed 3 times a week, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. Hyperkalemia is not uncommon in these patients, particularly after their long 3-day interval, and elevated potassium has multiple consequences for these patients. Rapid lowering is arrhythmogenic. We know that sudden death is higher on Sundays and Mondays. That's at the end of that long interval. Part of that is a potassium-related issue. So the use of these binders in that setting is also one that would be welcome, that was not included in the original studies. And here you can see that patients who had been put on patiromer and pre-patiromer, you can see the 3 months run up until when patiromer started, mean potassium 5.9, and with the use of patiromer on a daily basis, and you'll see the contrast of that in a moment, did lower potassium. So its utility in the hemodialysis population. Let me move to SCC, sodium zirconium cyclosilicate, ZS9 as it was called. But basically, it was the 9th iteration of the crystal that actually worked. So in contrast to the others, which were resins, this is a crystal. It's a crystal structure, and I draw your attention to that interatomic distance where you see the green potassium hanging out there. And that's because this crystal would prefer to have potassium other than any other cation. In its manufacturing process, it's charged with hydronium ion or sodium, but when it sees potassium, it traps it. And the reason is, take a look at the interatomic distance of potassium. 2.9, call it 3. Sodium too small, hydronium ion too small, calcium too small, magnesium too small. This crystal wants to trap potassium. The core studies, there were 3 core studies. They basically have 2 parts. One is a corrective initial phase that lasts arguably 2 days. There's one that lasted 3 days, where the dosing with SCC is 3 times a day. And then patients move to a maintenance phase. This study was placebo-controlled, very large study. Dose finding, you see various doses, 1.25, 2.5, 5, and 10. And the data, a lot of data points here, and I'm going to point out some features on one of the other studies, but I want you to take note. So you see the arrows down at the bottom. So patients are dosed in the first 24 hours at 0, 4, and 10 hours. And then on the next day, the same thing. Total of 6 doses, and then move on. This is the data with the 10-gram dose of SCC, which, as it turns out, is the recommended maintenance dose. But I want you to take a look at those little dots. Those little blue dots are baseline, 1 hour, 2 hours, and 4 hours. That's after just the first dose of SCC 10. And you see that at hour one, is a statistically significant decrease from baseline. And this was actually placebo-controlled. The placebo dots are not there because this slide will be busier than it already is. You can then see that compared to placebo, that there's a maintenance of normal kalemia. And then off drug, you can see that the blue dots, the SCC-treated patients, within 1 week, they're back to where they were at baseline. Speaks to the chronicity of hyperkalemia. The next study, the harmonized study, was, again, a 2-day TID dosing. The dosing here was 10 grams TID. Patients were admitted into the study if they were hyperkalemic. There was no upper limit to the potassium in terms of entry. This was an outpatient study, not an inpatient study, and you'll see some of the interesting data and how high the potassiums were in some of these patients. So it was 48 hours of TID dosing, and then placebo 5, 10, 15 grams. And what's shown here, again, is that first 48 hours. Here you'll notice the mean potassium was a little bit higher than it was before. And again, those first 3 dots, 1, 2, and 4 hours, are after that first dose of 10 grams of Lokelma. And you can see that the decrements at hours 1, 2, and 4 were 0.2, 0.4, and 0.5 milliequivalents at 4 hours. The mean time to potassium normalization, 2.2 hours. 84% of the patients were normalized by 24 hours. There were decrements in all the patients, and virtually 100% were normalized at 48 hours. A very, very impressive response. Here you can see that after the 2 days, this was a 28-day study. The last one was a 14-day study. And again, maintenance of normal potassium in the 5, 10, and 15 gram group versus the placebo. Just to give you some idea about the subgroups that were looked at. Entry into the study was hyperkalemia, but these patients had CKD, as you see at the bottom, heart failure, diabetes. 70% or so of them were taking RAAS inhibitors. These patients that entered this study had no recommendations for change in diet. Nothing was done to their RAAS dosing, and they were treated. It's very important to recognize that. Office patients. And you can see that in all those subgroups, there was significant lowering in that first 48 hours. Another interesting feature of SCC, this is the 10 gram dose. You can see that there are 3 subgroups of baseline potassiums. It was 5.1 to 5.5, 5.5 to 6, and greater than 6. All these patients were given the same 10 TID, but the more potassium that SCC sees, if you will, the more it will bind. So the absolute decrement in potassium was greater the higher the potassium. That's a very interesting feature. Higher potassium gets more lowering. This is a subgroup of patients, 45 patients whose potassium were in excess of 6, pulled from those 2 studies. And you can see here 1 hour, 2 hour, 4 hour. That's after that first dose of SCC. At 4 hours, the decrement was 0.7. Remember my 0.9 from the Reveal HD. That's not to say that this should be used as sole therapy in those urgent situations. But most of what we do moves potassium into the cells, and then in a few hours it's coming back out. The only thing that removes potassium from the body, arguably, diuretics, dialysis, and a binder. And you can see the impact of just a single dose of 10. I can tell you that my renal fellows very much appreciate this. Patients who come in hyperkalemic, we can manage them with the acute therapies, but they're given 10 of Lokelma as additional removal of potassium. In terms of side effect profile, with respect to SCC, GI issues are relatively low compared to placebo. There was some issue. It is a sodium-based, sodium zirconium cyclosilicate, much, much less than SPS. But at the higher dose, the 15-gram dose, there was some reported AEs of edema. Most of the patients with edema did require a change in their diuretic therapy. There was just one discontinuation of a drug because of fluid overload. Hypokalemia is a relatively rare event and is managed by lowering the dose. This was the third study, the long-term 1-year study. Patients here were given 10 TID for up to 72 hours. 80% of the patients were normalized after the first 24 hours. Came back, normal potassium. They then went into the long-term maintenance phase that went on for up to a year. These patients, about 75% of them were on RAS inhibitors, and over the course of the year, basically just shy of 90% either continued their then current dose of RAS inhibitor or actually had an increase in their dose of RAS inhibitor. So again, a very important permissive effect for this binder. The edema rate was comparable to what has been reported in other long-term CKD studies. This is basically just a long-term safety study showing the efficacy at the long duration of efficacy over a year. And I want to just mention one 3B study, and that's the dialysis study. And this is a placebo-controlled treatment of hyperkalemic patients on dialysis. Patients who are hyperkalemic were randomized to either placebo or doses of SCC starting at 5 grams. If their pre-dialysis after long interval was controlled, that was their maintenance dose. There was a 4-week evaluation period. Here, the dosing with the SCC is on non-dialysis days only. So these patients were mostly taking either 5 grams of SCC or 10 grams, 4 out of 7 days, and you can see the mean maintenance of normal potassium in these patients, both after their long interval and their short interval. So it's 60 years in coming that we now have binders that I would confidently say are effective, safe, easy to use, tolerable, and the data does support their efficacy and utility in the appropriate patient population in terms of being able to continue the appropriate medications for the comorbidities. With respect to patiromer, there is some non-specificity to the binding. You have to watch for the magnesium. The onset really is at hour 7, as opposed to onset of action 1 hour with sodium zirconium cyclosilicate. Starting doses are listed. I won't belabor that. They're in the package insert. I would caution one important thing about drug-drug interaction. These binders don't get absorbed into the body, but they can adsorb other drugs. And as a consequence, the recommendation with respect to patiromer is no other medications be given either 3 hours before or 3 hours after the dose in order not to adsorb that medication. With respect to SCC, it's interesting. It doesn't bind anything else. The only thing it traps is potassium, but it is a change in the gastric pH because of the drug, and therefore there's an alteration in absorption of weak acids, weak bases. There's a list of them in the package insert. And so here too, there's a recommendation not to take other medications 2 hours before, 2 hours after SCC. So the impact of the newer agents, I think I've shown data and I've seen the data. It's there to facilitate the appropriate RAS blockade. Whether it has an impact on improving diet hasn't been formally tested. Anecdotally, yes. Hyperkalemia treatment in ESRD patients has been shown. And I would argue that the treatment of severe hyperkalemia, adjunctive therapy with these binders, particularly SCC, because of its quicker onset of action, I think has a role in that setting as well. So with that, I'll stop and turn it back to Thomas.
So we're doing the tag team. So now that you've heard about the binders, let's spend just about 10 minutes with the other staple of hyperkalemia management, which is dietary adjustment. And this is going to be a form of panel discussion about diet. I will show you a few slides, and then we'll have a brief discussion with Dr. Clegg, who is eagerly awaiting return on Zoom. So as we mentioned, low potassium diet is one of those things that we throw at patients pretty automatically. So when somebody comes in with hyperkalemia, we send them to dietitian. If we have one, if you don't have one, you might tell them not to eat bananas. So that's unfortunately, that's what we oftentimes do. The question is, what should we tell patients, and when should we instruct them to have lower potassium diets, and how should that be implemented? And I show you a few guidelines that touch on this issue a little bit. I have to say that there's really not a whole lot of art or science going around about what exactly ought to be done. As you see, nice guidelines from the UK. They recommend low-K diet with persistent hyperkalemia more than 5.5. Jack, which is American, restrict dietary potassium to less than 2.4 grams per day in CKD stage 3 at higher. And then KDIGO, which is the nephrologist guideline, not surprisingly, it goes into the most detail. It starts by saying that direct evidence is lacking. And so go for it. But it's a valid strategy to treat acute hyperkalemia, and it hypothesizes that a general prevention strategy may deprive CKD patients of beneficial effects of dietary K intake. So there's your curve there, okay? So again, we end up with this conundrum. Yeah, restrict potassium in the diet, but are you helping the patient? Are you harming them? Because there are benefits of high potassium diet, in fact, and it recommends research, which we don't have. So how does dietary potassium counseling look like? And this is not my bread and butter, but as a nephrologist, I get exposed quite a bit to what my dietitians do. And this is not easy, folks, okay? Diet is complicated, all right? And it's regional. So I actually saw a cookbook in China, and I didn't understand any of it. And, their dietary recommendations are totally different. So you really ought to know what's in your supermarket, what's in your farmer's market, because that's what your patients will consume. And as you can see, it needs to go beyond don't eat bananas, all right? Because there's a lot of type of foods, and their potassium content is wildly different. So there is cheese and cheese, but not all of it contains the same potassium. Some is higher, some is lower. So I don't expect my fellows actually to know all this, okay? I need them to recognize the need for a dietitian and then send them to the dietitian. So what's the science? As I mentioned, KDIGO is kind of about science. Most of these studies I'm showing, in fact, all of them are observation studies that try to look at the association between potassium intake and various clinical outcomes. And because it's a complicated slide, I will editorialize and just tell you that the vast majority showed no association or a positive association, in the sense that higher potassium intake was associated with better outcomes, okay? And intake was measured either through urine or through dietary, surveys or various methods that dietitians use to quantify potassium intake. And this was done in populations with normal kidney function and those with dialysis and anything in between. So again, kind of a head scratcher, because we want to restrict potassium intake, but then whatever little science we have is telling us that maybe the direction is not what we would expect. What happened? Nothing. Okay. So what is going on there? All right. So just think about what are the foods that have high potassium content. And, this picture is, edited on purpose to look very nice. Okay. So it's a lot of colorful stuff. It cheers you up. But when you look at the type of foods, is essentially your DASH diet, right? So you have your fruits, your vegetables, and your nuts, okay? This is the type of diet that you want every patient of yours to eat, right? Especially those who are at high cardiovascular risk. So guess who are the highest cardiovascular risk? Is patients with CKD. So, this is the diet they should be eating, and this is the diet that we tell them not to eat because it might raise their potassium. So with diet too, we end up with this conundrum, with this dilemma of what to do about it. And to dig a little bit more into it, there's actually pretty good data about the many health benefits of high potassium diet, okay? And the co-author on this paper was Dr. Clegg, showing effects on lower blood pressure, decreased risk of stroke, bone health, nephrolithiasis, kidney stones are less likely on these type of diets. And then in patients with chronic kidney disease, there may be actually control of metabolic acidosis and so on and so forth. So a lot of health benefits, but then again, looming over it is this risk of high potassium, which makes it very difficult to implement these diets. So these were my slides, and since we have one of the world experts in this, I want to now bring to the fore virtually Dr. Clegg and ask her, how do you handle this, Dr. Clegg? What do you tell your patients? How do you reconcile this dissonance between the health benefits of high potassium diets and the risk of hyperkalemia?
Thank you so much. And I think that all of what you guys have talked about so far this evening has been spot on. And I think diet is incredibly difficult to handle, but it doesn't have to be. And so I would love to, instead of having that beautiful fresh fruit and vegetable slide with all those typical foods that we would tell our patients to avoid that are high in potassium, I would love to replace it with a slide that I think is even more important. And that is that we have now realized that food industries are adding a ton of potassium additives to foods. So if you look at a processed food, like a processed meat or processed juices, those things that stay on your shelf forever and ever, those are the items that are loaded with potassium additives. The potassium additive enhances the flavor, it enhances the shelf stability, and the potassium additives have really high bioavailability. And what I mean by that is that your patients consume a potassium additive and their potassium levels will go sky high. And so I think if we had the ability to sort of reverse the discussion and say, based on what we already were aware of, which is that data is a little squishy about this with respect to fresh fruits and vegetables, actually, the more data that's coming in recommends that our patients actually eat those fresh fruits and vegetables. What I think we now need to do is turn the conversation and say, eat the fresh fruits and vegetables in moderation, but eat them, but avoid your highly processed foods. That might be a message that we could really, really drive home for our patients and make a substantial impact on their overall serum potassium. I don't know if that helps or not, but that's sort of where I would go. Obviously, if you happen to have a dietitian that you can refer your patient to, that would be awesome, but a lot of you don't have that opportunity. I think what's really, really important and not always well understood is that actually the American consumer is already eating a very low potassium diet, which is difficult and not necessarily something we recommend. But if you look at when you're in your grocery store looking at those fresh fruits and vegetables, look at the baskets and the carts of the individuals around you. And what you'll find is they typically shop within the inside of the grocery store. They're in those aisles that have all of the processed foods. That's where they're shopping. You can find canned foods, you can find frozen foods, you can find foods that are in boxes where you just add water. Those are the ones that have all of those potassium additives that have that high bioavailability, and the ones that I think I'm most concerned of. If they shop around the perimeter of the grocery store where they're going to hit the fresh fruits and vegetables, the fresh meats, those are going to be the products that are not going to impact their potassium nearly as much as those potassium additives. So Zaba, I can stop there or add more information, whichever you'd like me to do.
So I had a comment or maybe a question to you. So this lesser effect of fruits, vegetables, is this because their fiber content and maybe motility enhancing effect and lesser transit time in the gut, or maybe their alkalinizing effect, which may impact potassium's shift into the cells, or a combination of these? Is there an explanation as to why their effect on potassium may be less, or maybe other things?
I'm going to answer your question by saying yes, it's both, right? So these fresh fruits and vegetables, especially, that would be another recommendation that I would make for you who are out there seeing these patients. Ask them to avoid the juices. The juices are going to be much more highly impacted with potassium because they're in a liquid form. But if they eat the fresh fruits and vegetables, the whole fruit, the whole orange, as opposed to drinking the orange juice, then you do indeed get that fiber that Sapo was just talking about that actually facilitates the transit of the potassium through the gut and out into the toilet bowl, basically. So I'm really, really a huge advocate for the fresh fruits and vegetables, not the juices, the actual fresh fruits and vegetables that are loaded in fiber. They also impact that overall acid-base balance in a beneficial way. And they also contain carbohydrates, which stimulate insulin release, and that insulin allows the potassium to be taken up into the cell. So there's so many benefits of eating these fresh fruits and vegetables. That picture that he showed you with the oranges, the avocado, the banana, all of those items are both high in carbohydrate, also high in potassium, but they're also high in fiber. So I think that as we continue to do more research on this, we're going to find that those fresh fruits and vegetables, those heart-healthy fresh fruits and vegetables, the ones that we've always told your patients to eat until they come up with a high potassium level, but it's going to be those fresh fruits and vegetables that are actually going to be incredibly beneficial for them to consume.
Great. Debbie, Bruce has a question.
Yeah, a comment slash question. You've written about this notion of postprandial hyperkalemia. The way I view things in terms of use of binders is to decrease the body burden of potassium. These patients may have now a potassium that's even minimally elevated, very mild. Postprandial, if they eat these healthy diets, there will be a transient increase in potassium, but it's happening at a lower level. What's your viewpoint of how a dietary recommendation fits in with the use of the new binders?
Oh, thank you for asking me that question. And you really beautifully talked about the fact that we need more data here, right? I really want to see the trial where we're actually taking people and putting them on high fresh fruits and vegetables with those binders. My hypothesis is going to be that you're going to see a perfect normalization of the potassium. You're not going to get that huge excursion after the consumption of these potassium-rich foods. And you're going to find that the patients are incredibly happy because they tolerate these binders so much better. So the binders, I believe, are going to allow us to be able to liberalize the diet, allow them to have these fresh fruits and vegetables, and really minimize that hyperkalemia that might be associated with consumption of a fresh fruit and vegetable, that immediate postprandial area. With the binder on board, you're going to have a lessening of that postprandial hyperkalemia. And I think the patient's going to do so much better overall. I think the binders are just an absolute new way of us being able to reopen the dialogue about diet and really help our patients. I had one patient that was referred to me. He actually owned an avocado plant, orchard, you name it, everything related to avocados. He had stopped eating his avocados. He lost an enormous amount of weight. He was chronically depressed. We put him on a binder, and he allowed him to eat some of his avocados. His mood brightened. He gained a little bit of his weight back. He was able to travel. It was like the binders opened a whole new world to him. And I've had other patients who've had something similar happen to them. And so I'm really, really excited about how well these are tolerated and how much they may be able to allow us to liberalize the diet.
Great. Well, thank you very much. For the sake of time, I think, thank you, Dr. Clegg, and we'll move on to the next section of our roundtable discussion, which we'll introduce with a brief case presentation. And so this will be case-based. Bear with me. So we have a 70-year-old, the 70, white male who presents for an initial evaluation to your office. Okay, he's transferring his care after recently relocating to the area. He has no subjective complaints. His history is significant for BPH, hyperlipidemia, CKD, and hypertension. He's an ex-smoker, no alcohol use, and works as a realtor. He has a family history of hypertension, and medication-wise, he's currently on atorvastatin, 80 milligrams a day, and losartan, 100 milligrams a day. His review of systems is negative. His blood pressure is 118 over 77 millimeter mercury, and his heart rate is 62 per minute. His physical exam is normal. Here are his labs. Upon presentation, as you can see, he has a normal sodium and potassium of 5.4, which is slightly above normal, CO2 29. His eGFR is 52 mLs per minute. Hemoglobin is normal. He has a UACR of 260 milligrams per gram and the fasting plasma glucose of 90 milligrams per deciliter. So here's our first question, and this is not this. We're going to use this as a starter for our discussion. And so my question is really directed at Dr. Shubruk. He's going to answer the question. So based on these characteristics, patients coming to you, no changes are needed. You would add hydrochlorothiazide. You would add dapagliflozin, 10 milligrams daily. You would add sodium zirconium silicate, 10 milligrams daily. Now that you've listened to Dr. Spinowitz's talk, add hydrochlorothiazide and dapagliflozin, or add sodium zirconium silicate and dapagliflozin. So, Dr. Shubruk, what's your take on this?
Yeah, I'm going to add a comment first, and I'll answer the question. So you all know these patients that you see, right? So these patients usually have multiple conditions, and when you're giving advice, you're really balancing a lot of things. And so as we go into these cases, I would tell you, don't go it alone. You don't have to do it all. You're part of a team. And that team might include a dietitian, might include a nephrologist, might include a cardiologist. So the first thing I might do is confirm these labs. Because, I don't know if this person ran a race the day before.
Okay, I'll give it to you. They're the same.
Sure. So now you've established what this person looks like, at least for the short period of time, if it's persistent, they've got chronic kidney disease. So we're going to have to address chronic kidney disease. And then the second thing is, what's the burden of this hyperkalemia? Is this high enough to be the primary problem, or is it the chronic kidney disease? So I think that's going to determine what you're going to do. And if I remember, they were normotensive.
Yes.
So you don't have a lot of wiggle room. So it's not the hypertension currently that's the problem. You're going to have to decide, am I going to look at the chronic kidney disease? Am I going to look at the potassium? And in this scenario, I'm probably going to prioritize chronic kidney disease. What are your thoughts?
Bruce? Yeah. Guys, certainly a life has changed in terms of use of the SGLT2 inhibitors in both diabetics and non-diabetics. So it's rapidly becoming a feature of a drug that we'd like to add in this situation in terms of significantly slowing progression of renal disease, and perhaps in addition to which alternatively cardiovascular complications that even if they're subclinical are probably there, and many of these patients
especially diabetics.
Yep. So I think DAPA has a role in this. There is some data to suggest that there is some associated caloresis, and that the hyperkalemia, when added, is less. So there may be less of a need for a binder. So maybe that would be a sequential approach.
Right. I guess I fully agree. So the simpler, the better. Of course, we will like it. Kill multiple birds with one stone. Occam's razor and all that. So dapagliflozin as an SGLT2 inhibitor for cardiorenal benefits. Now we talk cardiorenal. And then, the potassium, while it bothers us, it's kind of mild. And in general, you could expect a little bit of potassium lowering with an SGLT2 inhibitor. Hydrochlorothiazide, obviously, in somebody who is normotensive would be potentially problematic. In an older gentleman, you end up with hyponatremia. His sodium was 137, so that would be an additional issue. But remember that SGLT2 inhibitors are diuretics. So we usually don't like to combine with other diuretics, especially not starting concomitantly. So that would be another reason not to combine those. And so, we got it right. That's what. Yeah, so best answer probably number 3, adding an SGLT2 inhibitor, because this patient has increased albuminuria. Okay, that's the smoking gun there for us. His eGFR is mildly decreased. Okay, so let's see what happens when let me show you some literature data. Okay, so I'm not going to overdo this because there's a sea of data now there for SGLT2 inhibitors, which I'm sure that you're familiar with this. Nevertheless, there was a very nice meta-analysis. It came out about a year ago that summarized the data pertaining to renal and cardiovascular benefits with all SGLT2 inhibitors. So this combined data from 13 very large randomized controlled trials, including different agents. And you can see the numbers there for trials in diabetics, trials in heart failure, and trials in chronic kidney disease, specific dedicated trials in all these populations, totaling almost 16,000 patients. Non-diabetics was 16,000, and 90,000 was the total participants. And Remember, it's non-diabetics too. So we're talking about a diabetes drug, which is now being used in non-diabetics. So very, very interesting. This was the overall risk of the kidney disease progression. This was a composite outcome that combined various metrics, but in the end, it was a 37% lower risk of the kidney composite outcome, which is, in nephrology, this is huge. We haven't had anything like this ever. This is a massive decrease in scores. Interestingly, again, present in non-diabetics as well. Okay, despite this starting as a diabetes drug, we now hand it out to patients with various not diabetes-related chronic kidney diseases. It does not lower blood sugar in non-diabetics, so it's safe. And you can see here the various etiologies of kidney disease that were included in these CKD-based clinical trials: diabetic kidney disease, ischemic and hypertensive kidney disease, various glomerular diseases or other unknown diseases. And the key here is that there is no heterogeneity across groups. So even though some of these groups were smaller, so the confidence intervals are wide. So if you look at them independently, they may not be a statistical significance, but that's not the important point. The important point is that the results are very uniform and that there is no heterogeneity in their outcomes. And then if you dig into, for example, glomerular diseases, you have IgA nephropathy, you have FSGS, other GNs, and it's present in the benefit that is present in all of them. Yeah. Heart failure hospitalizations, another big benefit, at 23% lower risk in overall, and again, present in diabetics and non-diabetics. Acute kidney injury, okay, which was initially a fear of ours. Okay, we were not that familiar with this drug. It was a diabetes drug. So when we started using it, we initially brought patients back a week, 2 weeks later, because, what if it causes acute kidney injury? We knew that it has an ACE inhibitor-like effect, but it turns out that, in fact, AKI risk was lower in these clinical trials. It wasn't even neutral. It was actually lower than the risk of AKI in these high-risk patients. And then, as we discussed, the risk of hyperkalemia, this is one study done with canagliflozin, a post-hoc analysis showing a lower risk of hyperkalemia in patients treated with this SGLT2 inhibitor. And then another study that was only published in the form of an abstract that I'm showing you here with dapagliflozin showing similar results. So this too seems to be a class effect. And then that's why we all preferred to use an SGLT2 inhibitor in this patient with mild hyperkalemia because we expect it may be an improvement. So with that, let's move on to this patient. He's coming back 4 weeks later for follow-up. His blood pressure now is even better. And he's still bulimic on exam, and his lab work shows a sodium of 143. His potassium is still a little high at 5.2, and his EGFR is now lower. Okay, remember it was 53 initially, now it's 48, and he has a UACR of 180, which is considerably lower than what it was earlier. There was a decrease, but it's still elevated. So, what should we do now? First of all, Dr. Shubrook, are you concerned about the drop in EGFR? Does this patient have AKI?
Yeah, so I don't think he has AKI by any definition, but you said they're euvolemic, which I think is important. And we know that these agents are going to have an effect due to tubular glomerular feedback. And so there's going to be a decrease in burden to the glomerulus that you're going to see an acute drop in EGFR. That will resolve and still be better in the long run. So we're checking now to make sure there's maybe no hypokalemia, but I'm not worried about that at all.
Yeah, I mean, the data supports what you're saying. That is to say, there's a fairly consistent drop in small drop in GFR. It's transient, and basically, if you follow these patients out, the mean duration of follow-up in these SGLT2 inhibitor studies that were dedicated to look at renal progression, the mean duration of the studies were about 2 to 2.5 years. And you start to see the point where the benefit accrues and is evident after about 10 to 12 months. And that's a point where the placebo-treated patients continue to decrease and the SGLT2 inhibited patients still deteriorated, but at a slower rate. And that crossing, and it was about 10 to 12 months. So you've got to be patient with it. And it's best actually to tell the patient that there will be a transient decrement in renal function. They may see a little bump in their creatinine, but it's really being treated. They're being treated for the long haul. So it's important to tell them that up front, not to bail out. You want to watch for excessive volume depletion. If these patients have been needing significant diuretic therapy, you may want to consider cutting back a little bit as you start the SGLT2 inhibitor, not to avoid any significant drop in blood pressure. But these treatments are there for the long haul.
Right. So then let's see what we should do with this patient. No changes. Stop the data because we freaked out because of the increased creatinine. Should we add finerenone? Remember that was also in the guidelines. He's already on an ARB. Add sodium zirconium cyclosilicate for the potassium, or add finerenone and add sodium zirconium cyclosilicate at the same time.
Yeah, and I think this is a good time to highlight that it used to be, maybe you all remember this, that you would check for albuminuria, and if it was present, you put them on a RAS agent, and then you never check again. Those days are done. So now we have the ability to have multiple layers of treatment. We've just started a treatment, so I don't know that you have to do anything different today. But if there's still residual albuminuria 6 months or more later, you could consider finerenone. But I think at this point, you've got an agent that will work very well. You've already seen a reduction in albuminuria. You need to ride that out a little bit. And this is certainly something you could be doing in the primary care space.
Yeah, I guess, in primary care, this would be still unusual to have like triple combinations. And,
it shouldn't be anymore, though.
Just as an aside, there is data coming out on GLP-1 receptor agonists for renal protection. So it's getting more complicated. It's very soon. So there's one issue with finerenone is that its package insert says that you shouldn't start it with potassiums more than 5. Okay, so that would be a problem here, even though it's mild elevation in potassium. Remember that hyperkalemia does occur with that age. So if you stack it on, SGLT2 inhibitors and all, you will see hyperkalemia. So,
And actually in those trials, we couldn't put the patients in if their baseline potassium was 4.9 or greater. And it turned out to some of the patients, in fact, even during screening, might have been appropriate in terms of including them. But by the time baseline came around, they had a high K. And so the package insert has this cutoff of 5. But actually in the trials, it was even stricter. So I would say that that's the issue here with finerenone. The other issue is, this patient, I forget, the patient was on some RAS inhibitor, right? And an SGLT2 inhibitor, and now we're looking at finerenone. One of the problems with this particular agent was these studies with finerenone were started before we really knew about the impact of SGLT2 inhibitors. And so the problem is that very few of the patients were actually on this triple therapy, only about 5%. There was some suggestion that there was still some benefit. So, and in fact, there's studies now ongoing, looking at specifically adding finerenone onto an SGLT2 inhibitor to get some more data. So I would agree that if I would not add finerenone at this point, you've got two choices here. If you're worried about this patient's 5.2, that sometimes postprandial may now be 5.6, you might consider giving them the binder, or no changes needed. Keep an eye on it. Tell them to cut out the low-hanging fruit, quote unquote, the fruit juices, etc., to avoid significant postprandial. But and can I just throw in one point that I forgot to mention, I think hasn't been mentioned? Please make sure that when you get a blood test on these patients with marginal potassiums, that tourniquet goes on. They start to do this. The data is there. This is worth 0.4 milliequivalents of potassium. So I can't tell you how often someone is sent to me with a 5.6, and I have the tourniquet on if needed for the tech to get the blood, then take the tourniquet off. I tell them not to pump their hands, and lo and behold, the potassium is a little better. So that 5.2, that's what I would do with that one to start.
Well, I guess the only argument I would make is that if we agree that he has residual risk, okay, because of the residual albuminuria, you could make room for finerenone with a binder.
So you
that's if you start and I came up with this question, so that's my bias there.
Okay. You didn't do a cost analysis then.
work at the VA. So, but I can certainly see the validity of the argument of not changing anything. Again, if you are very aggressive, then if you give a binder, then the potassium would come down, and then you would have the opportunity to add finerenone as the third pillar of therapy in this very complex patient. And by the way, this is the algorithm that was used in the finerenone trials, which was incredibly successful in keeping patients on the therapy. Only about 2% of patients discontinued finerenone, despite having an incidence of 20% in treated patients of hyperkalemia, because they were very meticulous about, decreasing the dose or stopping the medication upon hyperkalemia, but then bringing the patient back. And as soon as the hyperkalemia was corrected, the drug was restarted as a lower dose. And it turns out that there is a tremendous fluctuation in potassium. So chances are that if you give it some time and you do something, especially with the binders. By the way, binders were not available in these trials largely. And then you can keep patients on the treatment. And importantly, in the finerenone trials, there was no mortality that was attributable to hyperkalemia. So I think that was an important point. So I added SCC, and the potassium was 4.4. And here are his labs, and now everybody's happy. UACR is lower, but still present. So at this point, you could consider doing something else, whether putting them on a GLP-1 receptor agonist if sugar requires it, or maybe finerenone. So that was the question that we had. But now we still have a few minutes, so we're gonna have the questions asked by you. Okay. So first one came to me. When restarting ACE inhibitors ARBs after stopping them due to hyperkalemia, do you restart at the prior dose or start at a lower dose and uptitrate? And that's a very good question. If you corrected the hyperkalemia, if you found the correctable cause and you think that it's not going to come back, you could try the prior dose. But to be honest with you, everybody's edgy about hyperkalemia. So I usually start at the lower dose, but with very aggressive uptitration. So I'm in a comfortable position of having a PharmD work alongside me, to whom I could dish this back and forth. So I asked her to bring the patient back weekly for repeat labs, and then titrate up based on blood pressure, potassium, serum creatinine, and then get them quickly back to the maximum tolerated dose, and then build upon that later. There is a question about metformin. Whether it results in hyperkalemia. It does not, right? Metformin is not. And by the way, the anti-diabetic medications in general, they're not hyperkalemia inducing. So they're fine, they're neutral. If anything, by correcting hyperglycemia, usually potassium control becomes easier.
Yeah, but you would want to reduce metformin if the GFR is below 45, and you want to stop metformin below 30. Not because of potassium, but the concern of lactic acidosis.
Very good. Yes, absolutely. That's pretty well established. 30 is the cutoff now. At 45, you decrease the dose. At 30, you stop it, just out of abundance of caution. And by the way, please educate your patients that metformin didn't harm their kidneys, right? Because every patient of mine comes in and says, metformin was stopped because it was hurting my kidneys. So no, it's the other way around. Okay? You have some questions?
Yeah, there was one here about results seen with the binders. In peritoneal dialysis, the incidence that we haven't looked at it in PD, and probably one of the reasons is our PD patients tend to not have high potassium. Their potassium is removed on a daily basis and is pretty efficient. So very often, if I think about it, actually, I've got more patients if I'm supplementing K. It's one of the benefits of PD. Another question about issues in patients who have bowel disorders, colon resection, potassium. Would the binders work in that setting? Well, no colon.
No binder.
Yeah, I mean, these patients were not included in the studies if there were bowel, issues in terms of motility. So they really weren't looked at. If you have a stable patient who's hyperkalemic with, bowel resection, arguably because SCC starts working essentially from the duodenum, you might get some binding, but those patients were not included in the studies. There was another question about issues of hemolysis in terms of blood drawing. I think the labs are pretty good. They pick up when there's free hemoglobin and there's hemolysis. My biggest concern was the one I mentioned, and not having that fist pumping when you draw the blood. It's really important. And the issue about cost comparisons and head-to-head studies. There are no head-to-head studies, SBS versus patiromer or versus SCC. They're not likely to be done. No one's going to test against SPS because why should the companies do the work that SPS didn't do in 1952? So it's not going to happen. But there are no head-to-head studies. Cost comparisons. The reality is, I don't do a lot of analysis of cost, but I've been told that SBS is not inexpensive. Therefore it's very comparable to the other two binders. But I would refer you to your local rep for further information. That's my tagline. I don't want to do any of these talks. But it's not free. It's not free.
I think the key is to talk to your pharmacy, talk to your system, because in the U.S. it's such an opaque system that, the wholesale price means nothing. Everything is about negotiated price, and it's wildly different in the various healthcare systems. So it depends on whether it's on your formulary and whether you're allowed to use it, and they use whatever they allow you to use.
Yeah, we got a couple here. Do you worry about a very large drop in EGFR with SGLT2 inhibitors? I kind of still follow the 30% rule. So if there's a greater than 30% increase in creatinine, you're going to call my nephrologist and say, hey, what's the story here? There may be a secondary condition going on. If it's less than 30%, make sure the patient stays hydrated and you can ride that out. The second question was, do you see hypoglycemia with SGLT2 inhibitors in people without diabetes? So you remember that the SGLT2 inhibitors reduce the renal threshold down to about 90. So really, you should not see hypoglycemia in most people who don't have diabetes. Now, there are some disorders where you will get rid of glucose, but abnormally, but that's rare. So the short answer is no. And if you have someone with diabetes and they have hypoglycemia, it's probably their sulfonylurea or their insulin that should have been reduced when you started the SGLT2 inhibitor.
Yeah, so okay, we have probably a last one here. It's interesting following up on this case where, let's say, we followed your advice, guys, and not doing anything. Okay, so if you have this patient, you have them on an ARB, on an SGLT2 inhibitor, there's still albuminuria and patient's seemingly stable. So what do you do after that? So I guess the question was, do you still keep following albuminuria? And I would say yes. So remember, you're talking to a nephrologist, so we can never have enough labs. All right. I mean, I tell my patients I'm the vampire. I'm a blind man without lab work. So what we see often that these numbers are not stable over time. Okay. Sometimes for explainable reasons, sometimes for unexplained reasons, we do see an increase in albuminuria. Okay. To me, that is a very ominous sign. So I see patients whose EGFR is very stable. When I see their albuminuria go up, not maybe on one occasion, but persistently, that to me is a red flag that a few years later they will crash, okay, and they will start seeing a decrease in EGFR. So the nice thing about albuminuria that it is a very quick marker, okay, it precedes loss of kidney function, okay, and it responds very rapidly to therapeutic interventions. So you can monitor it as a risk factor and intervene early. And you can also use it as a monitor of your therapeutic efficacy. I just love showing it to my patients that, look, we started you on the new medication. Look how your albuminuria went down to normal, and they love it, okay? And then if it increases, then you should consider what to do next. Oftentimes, practical tidbit is that it's blood pressure, okay? The most common reason for an increase in proteinuria is elevated uncontrolled hypertension, okay? Any control of hypertension will lower your albuminuria, but more so if you achieve it with a RAS inhibitor. Okay, and if then you need to intervene with one of these other agents, then you should not be shy about adding them or send them to a nephrologist, because at that point maybe the complexity is getting to where they need a subspecialist. I don't know if you guys had anything to add.
Yeah, now it just triggered a thought, and that was I want to reemphasize that the data for use of RAS inhibitors in the diabetic patient, arguably CKD, was based on maximal therapy. The classic trials, RENAL and IDENT, patients were maximized. They were moved to losartan 100 and irbesartan 300, and that's where the benefit was seen. The notion that 25 or 50, quarter, half dose of your favorite ARB is doing it in terms of renal disease, we don't have that data. And that, again, is one of the benefits of the binders. The cardiologists do have some data. They've got a couple of studies with half max therapy of an ACE inhibitor having an impact, but nephrologists, we don't have that data. I don't know what 25 or 50 of losartan does in terms of renal protection. You've got to maximize.
I know what it does.
Right.
It makes you feel better that you did something.
I would not stop the SGLT2 inhibitors as the EGFR drops. This is a medicine that's treating the heart, treating the kidney, even if it's not treating the glucose. And so maintain that and work with your other specialists if it was going to be considered to stop. But this is a medicine I consider to be a long-term medicine now.
Well, thank you very much, everybody. If you want to come to us and ask us questions, feel free.